Hey guys, my name's Sam and welcome to Prep Medic. This week's video, we are talking seizures, how to recognize them and how to treat them. As always guys, medical care changes over time. So as of making this video, I believe everything in here to be true and correct. However, in the future, when you're watching this, there might be nuances that change over time. So make sure you're doing your own research when it comes to medical care. Additionally, I'm just some guy on the internet. This is not medical training and does not authorize you to do anything. So make sure you are falling back on your own local protocols, state laws, and operating within your scope of practice at all times. With all of that being said, let's get into the video. All right, so today we are discussing seizures. It's a super common medical complication that we see all the time in EMS around the world. Now, seizures are broken down into a couple different categories, and for the sake of this video, I'm really trying to distill the information and make it relatively simple. This is not meant for medical professionals that treat this all the time. This is not a critical care in-depth dive into seizures and different modalities. This is really, hey, you see somebody having a seizure, what should you do? So with that being said, let's talk about what a seizure is. First and foremost, a seizure is kind of the random and sudden firing of neurons in your brain. It's just a storm of electrical activity, and this can cause a variety of different symptoms. So to really start getting into the weeds, we have two categories of seizures. You have focal seizures, and then you have generalized seizures. And each of those has a variety of different subcategories. For today's video, we are going to be talking generalized seizures. More specifically, we are talking tonic-clonic seizures because these are the most dramatic seizures you see on the street, and in my experience are the most likely to cause a major medical emergency involving the airway and trauma to the person experiencing it. So that's what we're going to be talking about today. Tonic-clonic seizures used to be called grand mal seizures, and they are characterized by somebody oftentimes falling to the ground and having uncontrolled muscle spasms, along with a postictal period after the fact, which we'll talk about later in this video. These seizures generally last between 30 seconds and 2 minutes. However, with somebody in status epilepticus, they can last for hours if not intervened on. All right, so let's talk causes. Now, there's a huge list of causes for seizures, and we can't go through every single one for this video. So I've condensed it down into a list of the things that are, one, most life-threatening for patients, and number two, the most common that we see on the ambulance. So first and foremost, we have major head trauma. If you see somebody get hit by a car, falls down, anything like that, and they have a seizure, that's a big deal. Next up, we have hyper and hypoglycemia. So that's going to be high blood sugars and low blood sugars can cause this. We have eclampsia in pregnancy can cause seizures, as well as brain infections such as meningitis, withdrawals from alcohol, as well as use of illicit drugs and other stimulants. Now, unfortunately, there are a huge population of people that have seizures that do not have any known cause, which is where the diagnosis of epilepsy comes from. These are completely unprovoked seizures, and we really don't know why they happen most of the time. So the biggest issue we see with seizures is going to be airway management. While somebody's having a seizure, they are oftentimes unable to control their own airway, keep their tongue out of the back of their throat, spit out secretions, and then a lot of times you will see vomit and other things that could obstruct that airway and cause a medical emergency beyond just the activity you're seeing. So a couple other things that can happen to people is you can have falling. So you can have trauma from falling from a standing position, whether they're on stairs or over a cement floor. That can cause issues. It can cause car accidents, drowning. If they're in the bathtub, they have a seizure. They're not able to protect their own airway. That's not totally uncommon, which is kind of scary. And then you can have pregnancy complications. So if somebody's having a seizure in pregnancy, this is generally due to eclampsia if they don't have a previous seizure diagnosis, and this is potentially life-threatening both for the mom and the fetus, as well as if the mom is not getting enough oxygen, neither is the fetus, and you can cause some long-term issues with that. All of this is to say that it is important that we manage somebody's airway during a seizure, and we get them the help they need. So what should you do if you see somebody having a seizure in front of you? First and foremost, we want to move everything away from that patient. We don't want a lot of desks for their head to bang into. We don't want them at risk for falling down the stairs. So if we have to pull them out of traffic or away from a dangerous fall or something like that, we can do so. Next, we want to take them and roll them into the recovery position. This is where somebody's on their side with their head supported by their arm. Obviously, don't force somebody into a position that they are not able to go. We don't want to break bones or cause further injury. Generally speaking, though, rolling them to their side is going to be possible. This is going to keep the airway clear, so if they have any vomitus in the mouth or they've bitten their tongue and there's blood, it will drain out the side. We also want to establish an airway. So gone are the days of taking a wooden spoon and putting it in their mouth. We don't want to do that anymore. There's an increased risk to the patient as well as your own fingers, and all it's doing is preventing some tongue trauma, which isn't that big of a deal in these cases. But we can insert a nasopharyngeal airway. Generally speaking, people are starting to shy away from an oral pharyngeal airway because of those same reasons, as well as when the patient wakes up or stops seizing, they might have a gag reflex and vomit, which is not something that we want to happen in these cases. Next step is going to be applying 100% O2 if you have access to oxygen, but a lot of people won't. So just keeping that airway open is a big deal. Now, if you think about it, start timing the seizure. When somebody's having a seizure in front of you, it's easy for seconds to become minutes and minutes to become hours. And we oftentimes get the time misreported to us. So like we'll talk about in the treatment section, we're really not going to start intervening for this patient as far as medications until they hit that 5-minute mark. When we hit that 5-minute mark, that's when some medications are delivered. So if you can report to responders that they've been going for 3 minutes, 5 minutes, 6 minutes, that's going to do a lot for establishing really rapid treatment for them in the back of that ambulance. Unless this is a known seizure disorder and you already know that they don't want an ambulance called for them, these resolve quickly on their own, we're going to activate 911. Now, pharmacological intervention on seizures is generally not indicated until they've seized for at least 5 minutes. However, keep in mind it takes an average of 5 to 15 minutes for an ambulance to reach you, and by that time, if they're still seizing, you're already behind the 8 ball. So my advice would be to call early for a seizure. If it turns out they don't need emergency intervention, they come out of it, it's a known thing, and you just weren't aware of that, it's not a big deal. That ambulance can get a refusal of care and go back to base. When that ambulance does arrive, the interventions that they're most likely to perform is providing a benzodiazepine, which is a medication that is designed to stop seizure activities. There is more therapies they might decide to do where they can secure the airway with an endotracheal tube if they've been seizing for a long period of time. There's some other secondary medications such as Keppra that can be administered, but the mainstay of emergency treatment is a benzo. A lot of children that have the diagnosis of epilepsy or known seizure activity will be given a rectal diazepam administrator, which is exactly what it sounds like. It is diazepam, which is a benzodiazepine that can be given rectally by a layperson. Generally speaking, this is given to a school nurse or somebody that is medically trained. Oftentimes, their parents will know how to manage the seizure way better than any responder coming to the scene. So if they have that, be aware that that is something that might be used for that patient. For the healthcare providers that might be watching this, if you are going to perform rapid sequence intubation on these patients, for your induction agent, ketamine and propofol both have really good profiles for seizure control and should be considered for your induction agent in these situations. Otherwise, rocuronium and succinylcholine will not actually stop seizure activity in the brain. It will stop outward muscle movements, however. After a seizure has occurred, the patient will probably experience a postictal period. This is a period where the seizure activity is stopped, but they're essentially resetting. They've exerted a lot of effort and their brain is resetting, their body's resetting. It will oftentimes be characterized by an initial unresponsiveness that will gradually get better over 10 to 20 minutes with gradual improvement all the way up to an hour. Oftentimes, this will come with some confusion. You can have very combative patients after this, so make sure that you're protecting yourself and that patient if at all possible. And then watch for that improvement. If the patient is not improving after the seizure activity has stopped, that is another sign that they need immediate medical attention. Moving on to seizure mimics, things that look like seizures, but oftentimes are not going to be your tonic-clonic grand mal seizures that we were discussing earlier. The one that's most commonly misreported to us in paramedicine is going to be syncopal episodes. So a syncopal episode is just somebody passing out, or if you're on in the South, it's going to be falling out on the ground. And when they do that, they'll oftentimes have myoclonic jerks where their arms and their legs will twitch slightly, and that's reported as a seizure. The way I usually try to differentiate that is going to be what they were doing beforehand, and then if they had a postictal period afterwards. If they don't have a postictal period, I'm far more likely to lean towards a syncopal episode. Now, a couple other mimics. We have TIAs, so this is going to be basically a transient stroke, a transient ischemic attack. Complex migraines, panic attacks, and anxiety, psychogenic non-epileptic seizures. So these used to be called pseudo seizures, and they changed the name. If you do the acronym for that, psychogenic non-epileptic seizures, it's literally penis. So I think some neurologist somewhere had a lot of fun making that one. We've got transient global amnesia, narcolepsy with cataplexy, and then paroxysmal movement disorders, which those are much less common and we don't really have to go into them for this video. I hope this video is helpful. If you have any questions, leave them in the comments down below and I will see you next week.